Can we improve our health as the valley grows? It's a critical question. Just look at our asthma rates or childhood obesity in the valley. It looks like we're headed in the wrong direction. So let's spend some time together exploring the path to better health for our region as we look to 2020 and beyond.
This program is made possible in part by the California Healthcare Foundation, ideas and innovations to improve healthcare for all Californians. On the web at chcf.org.
Welcome to our look at the future of health in our region and how we can access quality care for all of us here in the Valley. To help assess where we are and where we might be headed in the next decade are Bill Mueller, CEO and Managing Partner for Valley Vision, and Dr. Thomas Nesbitt, Executive Associate Dean for Clinical and Administrative Affairs at the UC Davis School of Medicine. Well, welcome to both of you, and let's get started now with Tom and a baseline for comparison. In your experience with family and community medicine as a doctor and a faculty member, now you're in charge of UC Davis's School of Medicine, many clinics. How does the healthy region look and feel to you?
Well, I think there are a number of indicators that concern us about the region. Some of the comments that you made at the beginning around childhood obesity, around asthma rates, particularly in the Valley, are a big concern. Some of the other issues that concern us particularly are around access to care, the ratios of primary care physicians to population, the ratios of specialty physicians to population, the overcrowding in our emergency departments, and the amount of primary care that's being delivered in our emergency departments. Those are all concerns that indicate that we may be heading for even bigger problems in the future.
So in a community that had a good quality of health care, what would that look like?
I think in a community that has a good quality of health care, first of all, you have a medical home for the patient. You have a primary care provider who coordinates their care. You have access to specialty care when the care goes beyond their expertise. You have appropriate ancillary services such as home health. You have opportunities for patients to seek out adequate mental health services, as well as the opportunity for patients to be involved in wellness programs.
How is technology changing medicine and well for the next decade here in the Valley?
Well, I think there's no question that technology is going to have a major impact on health care. I think all the way from the electronic health record, which allows us to keep track of the information about the individual patient. It allows us to have information move from one location of care to another location of care, which protects the patient from certain mishaps, the wrong medication being delivered or medication being delivered that a patient's allergic to.
You mean the scrawls that the physicians used to put on those tablets? This is eliminated when you have to write it on your keyboard.
Yeah, that's absolutely correct. But it also, the electronic health record allows us to do things that we weren't able to do before. And those are things like automatic alerts for when it's time for a diabetic to have retinal screening or to have other necessary tests done. It allows doctors actually to monitor themselves, to develop health registries or disease registries on their patients and see how their patients are doing in terms of markers like hemoglobin A1C for diabetics, et cetera. So it is changing. But I do want to say that layering on technology onto a broken healthcare system is not going to solve all the problems. We have to look at ways to use the technology in different ways to create new models of care that actually improve health.
What are some of those models that you are looking at for the future?
I think they range all the way from personal devices that are used to monitor your health. I think the cellular technology that can do things with body sensors that monitor your blood pressure, your heart rate, soon your blood sugar. And if it gets above a certain level, alerting you, but sending into your electronic health record. So we're not just having patients try and remember to write down their blood sugars on a certain day or their blood pressure on a certain day. But then it jumps up to activities like patients being able to be cared for, as I said earlier, in their primary care physician's office for specialty care, and allows a collaborative care model between a specialist and a primary care physician, which may actually be even better for the patient than sending a patient off hundreds of miles to see the specialist and have that discoordination of care.
Let's turn to Bill Mueller now. And Bill, you've been involved with community health for a nonprofit organization that has brought people together to try to improve health outcomes in this region. And one project that I'm particularly aware of involves the Hmong community. And when we had about 6,000 immigrants come from Thailand, where they'd been held in camps for more than a decade, they all came to this community, and your organization brought a lot of different groups together so that they could have a healthy experience as they became Americans. Can you tell us a little bit about that?
Sure. Well, we called it the Hmong Health Collaborative, and we were funded by the California Endowment. And my organization was sort of a coordinator of that effort. We brought together 10 nonprofits spanning the greater Central Valley, and it was an area of great concern for the California Endowment. Here we had not only 6,000 refugees coming in from Thailand, but in California, of all of the Hmong that are living in the United States, about 38% are in California, and of that, about 80% are in the Central Valley. Now, these folks are just amazing, amazing people, very family-bound, very tradition-bound, but they come from a tribal sort of background, agricultural background, and so the whole orientation is not one that lends itself towards a Western healthcare system.
Especially if you're in your first months and years of being here in the United States.
Absolutely. Imagine going from a truly agrarian society and being dropped in Fresno, and all of the social services that would be available to you are really foreign. Not only the language, but just how the whole system works. And so a lot of our initial effort was in capacity building. How do you navigate the health system, especially a system that may not be familiar with shamanism, which is the method by which healthcare is delivered in the Hmong community. So not only did you have significant language barriers, the Hmong community don't have or haven't had a written language. You have an agrarian society that's trying to adapt to modern sort of a medical system, and you have a language barrier that's significant, and then you have very significant poverty education barriers as well.
So, Bill, it occurs to me that some of the things that you learned about helping them be a part of the health system here would probably apply to others in our population as well. So what paths did you find that were successful?
Well, it started out with truly bringing them into conversation with the health systems themselves. And so often that's a difficult thing. So learning about the different cultural practices and learning how to navigate was sort of a very basic first step. The capacity of these organizations grew over time. And what our project ultimately evolved into was a focus on systems change. Not only political change, but systems change, working within the health system to try and work on ways that we could help not only serve that particular community, but the community at large. And so whether it's a cultural barrier, culturally appropriate health care, or language access barriers, and simply the complexity of trying to navigate a health system which doesn't lend itself for easy decoding. Being able to do that, we have proven through this project, through the strength of their own efforts, that they can be successful. And they have been successful, and we're seeing positive healthcare trends because of this effort.
Well, in the Asian American community, the population over the next 10 years is going to be pretty stable. It's around 8% of the Valley's population, but the Southeast Asian community is going to grow, probably more because of just birth rates within that group. African American population is going to be steady at about 5%. But we are seeing a significant change as the Caucasian population lowers and the Hispanic one increases. And it's possible that by 2020, 40 or 41% of the Valley's population will be Hispanic. They will be the most numerous population. But Tom, we've got some other demographic changes. The aging of the boomer population as they begin to retire. We're going to have a lot of young families too in the Valley. And so how do the demographics affect the ability of our region on the whole to have good health care?
Well, I think the aging population, particularly in more remote areas, creates a significant challenge. I think this generation of seniors wants to age in place more than any generation has in the past, and I think we're going to see that into the future. And how do we make sure we can deliver the care that they need to allow them to age in their homes, not have to go to facilities, et cetera? I think, again, technology has a role to play, being able to deliver care into the home. There are home health programs where people come out and visit, but in more remote areas where the travel times are greater, the expense of that is sometimes prohibitive. So I think we can rely more on technology, even video conferencing into the home. The VA system has had some very successful projects that have shown that when you use telemedicine in the home, it reduces hospitalizations and emergency room visits. We also, on the other end, we have younger families. And so children tend to have a lot of preventive health care needs, but also they have some illnesses that require care by some specialists, for instance, asthma and those sorts of illnesses. So we need to make sure that we have access to not only good chronic disease management programs for them, but also have access to specialists when needed in emergency departments and other places.
You know, there's a concern that I see in Merced County where about a third of the women do not see a healthcare professional in the first trimester of their pregnancy. What are the ramifications of somebody not having that kind of access to health care?
Yeah, late prenatal care is a big factor when we look at things like premature births and other complications of pregnancy. It's also just an indicator of how well the health system is working, how well educated the population is in terms of health, and it represents a significant issue. And low birth weight and prematurity have numerous consequences, not only expense, but they have often long-term consequences on the child and greater health care expenses as they get older. So it is one of the first indicators of a broken healthcare system in my mind, and I think it's something we really need to make sure and address.
And a very expensive one, because if we don't get some of these fundamental things taken care of early in a child's life, we're probably going to see that child and maybe the entire family in the healthcare system, and it makes it more expensive for everybody. Bill, I know that you're working now on a study of the economies of some of the rural areas in the Sacramento region, and land use and transportation and how that's affecting community well-being as well. Do you have any thoughts about how the rural areas and community health interplay in the Sacramento area?
Well, I think there's a strong interplay between health and our rural communities. And I just sort of echo what Dr. Nesbitt said about the fact that we are seeing health disparities, particularly in rural areas, when it comes to the locations here in the upper reaches of the foothills into the Sierra Nevada. Transportation barriers are a significant problem. Technology is a way of being able to address that. But we have to find a way to be able to get greater access to primary care physicians and greater clinic access there. And the issues, as you know well, are only going to grow more challenging over time as we all continue to to get older, and the amount of people that are going to be needing care are going to grow. It really takes us back to whether we focus on sort of a prevention model first, and how much effort we put there, and I have to applaud many of the health systems with being so forward-leaning, focusing on healthy living, focusing on obesity prevention, the taking in of healthy foods, fresh foods, and how critical that is, exercise and so forth, to address things like diabetes, asthma, and heart disease, where we're seeing such a significant increase over these last few years.
You know, Bill, we're going to turn to our audience questions in just a minute, but it's interesting how employers are getting involved with the health of their employees now. You work with a lot of companies here in the Sacramento region. My employer just contacted me with an online analysis and asked if I wanted to participate in a Get Healthy campaign. So now every day I go on the computer and log in how much cardio exercise I get, and you know what? It's kind of made me do more of it. So there's a role that we see from the employers because the high healthcare costs affect them too.
Absolutely.
Yeah. So let's move now to where we are today with the health of our region. And the Great Valley Center recently did an indicator report that looked on a county-by-county basis at the trends in the Central Valley and compared them to other parts of California. So let's take our pulse on the health of the Valley right now with this video.
Are we living healthy lives in the Central Valley? The Public Health and Access to Care Indicator Report from the Great Valley Center shows little progress over the last 5 years in getting healthier. Poverty is playing a role, but so are the lifestyle choices people are making. There is a shortage of doctors as well. The Central Valley has the highest death rate due to diabetes among the regions of the state. 15 of the 19 counties do not meet the Healthy People 2010 goal for stroke-related deaths. Every San Joaquin Valley county exhibits higher rates of coronary heart disease than the state average. There are some improvements for children. Asthma rates are higher than the state average, but infant mortality is dropping in the valley and the state as a whole. The Central Valley has a high percentage of children entering kindergarten fully immunized, 73%, a significant improvement over the last indicator report in 2003. While improved over 5 years ago, the Central Valley has the highest rate of women who are not receiving adequate early prenatal care. 1 in 5 pregnant women in the valley is not seeing medical professionals early in her pregnancy. In Merced County, it's worse, 1 in 3. Where are the healthiest people in the valley? El Dorado County does well in most indicators, and the North Valley stands out in a number of areas as well.
So let's turn now to our studio audience with a few questions for Bill Mueller and Dr. Thomas Nesbitt.
I'm Karen Fleming, and I'd like to know what's being done now to attract new doctors and medical professions out to the rural areas.
Well, there are a number of things being done. Our medical school admissions processes look at physicians look at students who are interested in rural communities. But one specific thing that's happening is something called the Rural Prime Program, which is a program that specifically is training physicians for rural communities. It's a 5-year program rather than a 4-year program. It's started at UC Davis. These students will actually receive a significant portion of their training in rural communities rather than in an urban hospital. So we'll tie them back to those communities, both in their training and in their experience during medical school.
Good. Let's go on to our next question.
My name is Ralph Ochoa. My understanding is that the PRIME program augments the number of doctors that will be graduating from the schools that exist now. But the statistics project that that still isn't the number that we need in rural areas. And if you add the effort at the national level and state level, with unions asking for more persons to be covered by insurance, if you don't have more doctors, then what will the existing doctors be able to do as far as giving any care?
Well, clearly the physician shortage is quite significant, and there's estimates that we're going to be thousands of doctors short in California in the next decade. I think that one thing we have to do is to look at collaborative models of care between a number of health professionals who can provide various types of care, and physicians can work with those professionals, nurse practitioners, physician's assistants, etc. We clearly do, however, need to train more physicians. It's a very expensive endeavor to train physicians, but it's clear that that is something that we need to do. We need more medical schools, and we need the medical schools that we have to expand the numbers that we're training today.
Do you think by 2020 that we'll have a new medical school here in the Valley?
I think that's unclear. A lot has to do with the economy and the available resources to make that happen.
So there are plans to do it at UC Merced, and I know there's some cooperation with UC Davis on that front, but it's not something that we really know is going to go forward, or at least not at a pace that would have it in place by 2020.
I think pace is the key term there. I think we definitely need to have some sort of program that trains physicians for the Valley, and I think we need to do that sooner rather than later. And exactly what that program looks like, whether it's a collaborative program between some of the existing medical schools or when a new medical school is created, is yet to be determined.
Good. Please share your question with us.
Hi, my name is Betty Green Heffron, and I'm wondering if you could share with us what you think are the main drivers of the rising health care cost in the Valley?
That's a complicated question because there's a lot of things that are affecting the cost of health care. What are some that occur to you first and foremost?
I think some of the drivers of increased health care costs are the fact that we're not doing some of the basics as well as we should. Some have to do with some of the issues we've talked about earlier: obesity, air quality causing more flare-ups of asthma, etc. But when patients aren't able to get primary care and preventive care, they're more likely to end up having to seek care in the emergency department if they don't have a primary care physician. That is much more expensive care than care in a primary care provider's office. So that's one of the drivers. I think some of the other drivers involve discoordination of care. When patients go get the same test over and over in different sites of care because their records aren't linked together, so no one knows that they've already had that blood test or they've already had that x-ray, it leads to duplication of services. So I think that's another one of the things that we could change with some of the technology solutions that we've been talking about.
It's also an interesting thing, Bill. I don't think that the public in general understands the economics of the healthcare system. You're involved with community education. Mm-hmm. That's probably something that more work needs to be done too if we're going to have better health here in 2020.
No doubt. I mean, one of the things that we know from the nonprofit health systems is that their emergency rooms are literally being overrun, and they're seeing a spike, especially under the current economic tailspin that we've seen over the last several months. And there's a great deal of hidden opportunity here in that we have community-based clinics, both supported by the health systems, student-run clinics, nonprofit-based clinics that are in many different communities throughout the area, but they're really not well known. And so there's a lot of emphasis being placed right now on simply notifying and getting the broader public aware that there are alternatives to going to the emergency room that can meet their needs and meet it in an expedited way.
Good. So one more question.
My name is Leanne Trumbull, and as a follow-up to the community-based clinics, are there any plans right now to advertise those clinics or any models that are being developed to bring more of those clinics to the rural areas, keep people out of the non-emergency situations?
Do you know of any efforts to make that more widely known so that we can use the gamut of healthcare that's available to us?
Well, I think in some of the government programs that are being discussed today, I think there's a effort to allow the federally qualified health centers to be more efficient, to add technology, to do a number of things to help them provide better and more efficient care, but also to expand their services. I think one of the problems is, however, that a lot of those clinics today are overwhelmed with the number of people that they have to take care of. They're having challenges finding providers as well. So it's a fine balance between advertising where those clinics exist, particularly as many of the people now are finding themselves with either inadequate health insurance or no health insurance, so that becomes their only alternative. So I think we're going to face certainly a greater challenge in that area before it gets better.
Well, thank you very much, Tom, and to you as well, Bill. Thank you for your questions, and thanks to you for being with us as we're exploring access to health care in the Central Valley. Thoughts about 2020 and how we're going to get there in good health.
This program is made possible in part by the California Healthcare Foundation, ideas and innovations to improve healthcare for all Californians. On the web at chcf.org.